Hey, good afternoon, everyone. Welcome to the Swetland Seminar Series. My name is Lydia Webb. I'm a research associate here at the Swetland Center for Environmental Health at Case Western Reserve University. So we're excited for you all to join us today and excited for Katie Ettman's presentation. A couple of housekeeping things before we get started. If you would like to, please share your name and organization you represent in the chat box. And then if you have any questions throughout the presentation, feel free to pop those in the Q&A, and Katie's going to lead us in Q&A probably like the last 15 minutes of the seminar today. So we're going to start with some intro slides about the Swetland Center. If you're not familiar, in the late 1950s, David Swetland and Marianne Swetland felt not enough was understood about the unintended health consequences of chemical agriculture and industrial products in our environment. So they focused the Marianne Swetland Professorship of Environmental Health Sciences on preventative medicine and the threats of man-made environmental hazards, so that all graduating doctors would have an interest in and understanding of the impact of the environment on human health. And today, the Swetland Center continues Marianne Swetland's legacy by building partnerships to find and scale solutions to redress the environment's disparate impacts on low resource populations in Cleveland and beyond. And as research continues to demonstrate the vital connection between the environment and health, our center is positioned to respond. And our mission is to study the complex interplay between environmental determinants and population health outcomes. And we place a special emphasis on community-engaged approaches that address the role of structural racism in creating and sustaining environmental health inequities. We seek to translate our findings into policies, practices, and relationships that promote community and population health equity. And if you're interested in learning more about the Swetland Center, I'm going to pop these links in the chat in a minute. You can check out our website or email us. We also have a link tree that I'll put in the chat as well. So our next Swetland seminar is going to be on February 18th from 9 to 10 a.m. on Zoom. And it's a panel presentation moderated by our director, Darcy Friedman. And it's all about digital strategies for improving healthy food access among SNAP consumers. So the case of the Produce Path app. So we're going to have one of the farmers market managers who's been testing out the Produce Path app, Tracy Sangri from the Cuyahoga Valley Farmers Market. Dr. Wuswa Yamoa, who's a research scientist here at the Swetland Center, and Katie Poppy, who's a research associate here at the Swetland Center as well. So they're going to focus their discussion on the development and dissemination of the digital strategy, the Produce Path app, to connect SNAP residents to farmers markets in Northeast Ohio. There is a QR code there if you want to scan it. I will also put the registration link in the chat. And we're also going to have a Swetland seminar on Tuesday, March 18th from 9 to 10 a.m. Virtual as well. And that will be with Dr. Myron Lard Jr., who's a postdoctoral research scholar in the Department of Forestry and Environmental Resources at North Carolina State University. He's going to present on the analysis of soil samples collected within a 2-mile radius of the train derailment in East Palestine, Ohio, last February 3rd, 2023. So he'll be presenting on March 18th, and I'll put that registration link in the chat as well. Okay, and we do have another announcement from the Swetland Center. So the Nourishing Power Network is committed to growing 10 nutrition equity zones in Cuyahoga County by 2030 to realize food justice through community-driven change. And to accelerate this progress, they recently invested in planning grants to support the development of 2 nutrition equity zones in Cleveland. And these grantees have deep connections to the community and extensive experience doing food justice work. So working together, each grantee collective is going to unify their food justice work as a nutrition equity zone. And so they just released a request for proposals, which is due next week, the 29th by midnight. They're seeking support to create a branding toolkit to ensure a consistent, clear, and impactful message to strengthen the identity and support outreach efforts of the emerging nutrition equity zones. They're also seeking support to disseminate the branded materials over a 3-month timeframe. So I'll put a link in the chat to the RFP so you can learn more and apply. The term of service is February 17th through July 30th. Maximum bid is 10,000. And again, it's due January 29th by midnight. Okay, so the reason we invited Katie Ettman to talk today, one of the projects at the Swetland Center is REACH, which is the Center for Disease Control and Prevention's Racial and Ethnic Approaches to Community Health Grant. And that was awarded to the Cuyahoga County Board of Health from December 2023 to September 2028. And so we at the Swetland Center, our team is leading one part of the nutrition strategy for that grant. And our goal is to increase the number of people using produce incentives, Produce Perks Midwest, and produce prescriptions, and also increasing the number of clinical sites that are prescribing produce for patients. So we're focused on areas of Cuyahoga County with high food needs, where at least 50% of the population identifies as Black or African American, and or 20% identify as Hispanic or Latino. And so we invited Katie today because one piece of our REACH project is the Produce Prescription Working Group. So we're partnering with the Health Improvement Partnership Cuyahoga, or HIPC, which was established to unify and sustain, well, they're creating this Nutrition Equity Committee. So there's one working group, the Farm to Early Childhood Education, and within our Swetland Center's REACH project, we're leading the Produce Prescription Working Group, which is focused on developing and promoting policy solutions to increase the number of clinical sites prescribing and the number of patients receiving produce prescriptions in Cuyahoga County. So the end goal is to develop policy supports to ensure anybody in our county who needs a produce prescription can get one, regardless of healthcare provider, location, or insurance status. And we're looking to inform the development and implementation of policies that expand and sustain culturally relevant produce prescription programming that is going to maximize freedom, agency, and dignity in food traditions that lead to holistic health among patients in areas of high food need, builds wealth among Black and African American, Hispanic, Latino growers, distributors, and nutrition educators that are involved in produce prescription program delivery, and also results in healthcare savings among clinical providers and insurers. So as I mentioned, we invited Katie Ettman, our speaker today, because she has significant experience advocating for policies that have expanded access to produce prescriptions and other food as medicine programs in California. We're excited to learn about Katie's work and see how we can apply her learnings to the work of the Produce Prescription Working Group. So welcome, Katie. Katie is a lifelong advocate. In her role as the Deputy Director at Fullwell, she works to build a healthy, just, and sustainable food system through local and state level policy change. Before jumping into policy headfirst, she worked with the Food Bank of the Rockies in Denver, Colorado, managing the procurement of fruits and vegetables for 30 counties in Colorado and Wyoming. When Katie isn't at work, you can find her eating her way through San Francisco and searching for the best soup dumplings the city has to offer. I'll pop a link in the chat for the Fullwell website, and I will turn it over to you, Katie.
Incredible. Thanks so much. I'm so excited to be here with you all, and thank you for the really kind introduction. I'm just going to pop up my screen and get things rolling for us all today. So hopefully we're in the right place. And you want to hear about integrating food into healthcare, particularly all the way from individual programs to the policy level, which is where I live in all of this work. And so just a quick overview of where we'll go today. First, I'm going to do a really high-level background about what is the connection between healthy food access and chronic disease prevention or treatment. Why are we talking about food in a healthcare context? That's the question we're looking to answer. Then I'm probably going to introduce a new term for most of you, which is medically supportive food and nutrition. People talk about as food is medicine, sometimes food as medicine, but I want to make sure we're all on the same page about what we're talking about. Then I want to talk about the trajectory of this environment. How across the nation are we fitting into, or are we fitting food into healthcare, and what is the future of that work? And then I'll do a little bit of a deep dive on the work we've been able to do in California as it relates to integrating food into healthcare. So first, this chronic disease and healthy food connection. And I always like to preface this with, I am not a doctor, I am not a nurse, I'm not a physician, I'm not a nurse practitioner, but I am incredibly lucky to be surrounded by incredible folks across all of those different professions. And so hopefully I can do them justice in this bit of background. So first, to just give a little overview of the United States, and I would guess that most of this doesn't come as a surprise to anyone, that 6 in 10 adults in the United States suffer from a chronic condition. 4 in 10 adults end up with one or more of those chronic conditions. And unfortunately, that means it is the leading cause of death and disability. And then it's also incredibly expensive to take care of patients with different chronic conditions. So actually, we can account for about 90% of our healthcare spending comes from treating chronic conditions. But what do chronic conditions have to do with food? This sort of chart that you're looking at here shows you that dietary risk is actually the #1 risk factor as it relates to death and the people that it is affecting. I think the thing that for many public health folks is a little surprising is at this point, diet risk has actually outstripped tobacco use as some of our leading causes for death in the United States. But all of this is not doom and gloom. I don't like to focus on the doom and gloom. That's not what we're trying to do here. Instead, we're going to look at solutions. And so I'm really excited to share that there is a wealth of research and data from across the country and around the world that shows that food and healthcare can do a lot of different things. One of them is that it often reduces unnecessary healthcare utilization. And I like to point out unnecessary because some healthcare utilization is really good. We want people to go to their primary care physician for an annual checkup or go get your well visit each year. However, we're really hoping that most people aren't ending up in the hospital or being readmitted to the hospital. And so studies have shown that for folks who leave the hospital and are provided meal services, that it can actually reduce their rates of readmission, for example. There's also some modeling studies that have been done that show if we subsidized the purchase of fruits and vegetables for folks, we could actually see in the Medicaid and Medicare population across the country anywhere from $40 to $100 billion in potential savings as it relates to looking at food instead of just our traditional healthcare model. So that's all of the money, the healthcare utilization. But I think the part that really inspires me is actually some of the positive health outcomes that we're able to see. So like I said, I'm not a doctor, but I will note here, HbA1c, it's really average blood sugar, an indicator of diabetes. Studies show statistically significant drops in that average blood sugar to the point where it is enough to improve your overall health. It's not just a drop in a number. And then my favorite study to talk about is the second bullet part down about preterm birth. So we were really lucky that a research study was done in San Francisco, California, that showed when you provide pregnant people with a $40 per month produce prescription, that they could go into a retail environment and buy free fruits and vegetables, that we actually saw the odds of preterm birth fall by 37%. Anytime I talk about that number, the words I use to describe it are cuckoo bananas, because a 37% reduction in preterm birth has huge implications for obviously the birthing person, obviously the tiny human that's been brought into this world. And then if you're looking at the hard facts and numbers, has a huge impact on our bottom line. Premature babies are really expensive to take care for and make sure we can keep them healthy. And so we really like to see that this hits sort of all the different talking points as it relates to integrating food into healthcare and why we might want to do that. But before I dive too deep, I want to make sure that we're all talking about the same thing. So you heard integrating food into healthcare. I already mentioned medically supported food and nutrition. I think I've already said produce prescriptions. And some people on the line might be going, wait, what? She's gone too fast. I don't get it. First, I want to note that I am not talking about detox teas or anything that you might see hawked on Instagram. I never thought I would get to put up pictures of Kim Kardashian in a work presentation. I've now done this a couple of times and it makes me giggle every time. I hope you're as amused as I am. But this isn't what I'm talking about. We know that people use food to get healthy all the time and there's sort of these quick fixes, but instead, I'm talking about food integrated into healthcare to help prevent, reverse, and treat chronic disease. And so this is a really common visual. This is out of the folks over at Tufts in Boston that sort of shows the integration of food into healthcare in a pyramid scheme. You'll see here that we have sort of population level prevention strategies. That includes things like SNAP and WIC and school meals, just ways that we're making sure that people have access to food. And then I've drawn in this little orange line that lots of people would say, once you get above that orange line, that's when we're talking about food is medicine or food as medicine. So produce prescriptions to help prevent, reverse, and treat chronic disease, medically tailored groceries or medically tailored meals. I'm so happy that our colleagues from across the country, but particularly Massachusetts, have really pioneered this visual and model. But I will admit it never felt quite right for our advocacy in California. And so I'm going to introduce you to a slightly different graphic depiction of sort of this environment. And so here we use the word medically supportive food and nutrition in California. And that is in part to differentiate ourselves from selling detox tea on Instagram. We don't want to get anyone confused that that's what we mean. We are really talking about medical integration. And that's why we have stepped back from, in lots of our language, using food as or food is medicine, even though colloquially we're really gaining traction on what that means. And so instead of representing this as a pyramid, we like to divide this into the different ways that people might access food and different supports. And so you will see here that we have two different types of meal interventions, and then a couple different types of grocery interventions, as well as any of these that can be paired with wraparound services, cooking classes, nutrition education to help amplify the impacts of providing a person that food. So I'll walk you through a few different examples of what I mean by those different terms. So first, medically tailored and medically supportive meals. I think medically tailored meals are probably the most well-known medically supportive food and nutrition intervention. And they are meals that are tailored to an individual's different chronic conditions, whether that be one or multiple, as we saw earlier is pretty common, by a registered dietitian, and they are often delivered directly to someone's home. Medically supportive meals, at least in California, we have generally seen this as generally healthy meals. Think about a more traditional Meals on Wheels program, where a healthy meal is delivered maybe to an older person's home. In both of these instances, we think of these as pretty high touch, high intensity interventions. So often medically tailored meals are an incredible fit for someone who, for example, has just been released from the hospital after a stroke, because they can't grocery shop for themselves, they might not be able to cook for themselves, and this is a way to support them in making sure they don't return to the hospital. We also have medically supportive and medically tailored groceries. That same distinction between tailored meals and supportive meals holds here as well, which is that tailored groceries are those tailored to an individual by a registered dietitians based on their different chronic conditions. And medically supportive is going to be generally healthy, fruits and vegetables, whole grains, that sort of thing. Another key term we've used here in the state, and we have a really robust food pharmacy program in San Francisco, is a food pharmacy. And this is the idea that instead of maybe a box being delivered to your house of groceries, that instead we are actually co-locating groceries in a healthcare setting. So imagine like this, a pop-up farmer's market at a clinic where an individual can come and shop for their own items, and that at the same time, they're likely to meet with either a dietitian to have a meeting with them, or they're going to get their blood pressure taken. So the idea is a really tight link between your healthcare institution and you. And I will say in this particular model, we've seen some really great co-benefits of actually bringing people back to necessary care. People who haven't gone to see their doctor in years, people who are maybe haven't had their medications checked out. Like, do I have any adverse interactions? Because they haven't been engaged in their care. And so this can be a really great way to obviously provide the food that they need to stay and get healthy, but also to bring them back into the healthcare setting. And then the one that you've already heard me mention today, produce prescriptions, but these are often cards or vouchers like you see here, where an individual can go out into a retail environment and buy their own free fruits and vegetables. So that could be a farmer's market or a corner store or a big box grocery store in your neighborhood. And we like to think of this as in many ways giving people ultimate flexibility so that they can choose the fruits and vegetables that they know, love, and know how to cook. And so that's what we're talking about when we're talking about medically supportive food and nutrition, at least here in California, and hopefully gives you a decent idea of where we are and sort of understanding this work and making sure we're speaking the same language. And so this next bit here is about where we've been, where we are, and where we're going. And so I want to name for everybody that in most instances across the United States right now, all of these different types of programs, whether that be produce prescriptions or medically tailored meals or any of the above, are philanthropically funded, which is incredible. We need philanthropy to fill in the gaps. But the reality of that is that it means that these programs are pretty unsustainably funded. I don't know how many of you in the room work at nonprofits or have worked at nonprofits, or hey, maybe you've worked with them and know that you might get a grant for a year. If you're really lucky, you'll get a grant for 3 years. And so if you start one of these programs and say, start providing patients with uncontrolled diabetes access to a food pharmacy, what happens when that grant runs out? And now that person no longer has access to that care to continue to help improve their health. It also means that there's often a lack of true integration. So someone goes in, they buy the food, maybe a doctor is the person who sends you to that food pharmacy, but maybe it's actually just a self opt-in, that it's not really connected to their care, it's just a value add. And then where we are really lucky to sit in numerous states across the country is in this middle section, Medicaid waivers. So if any of you are policy wonks, these are often known as 1115 waivers. And these waivers are an opportunity that every state in the country has to ask the federal government for exemptions to Medicaid rules to pilot and test new and innovative ways to provide care. And so these Medicaid waivers, particularly the one that's been used for food and healthcare, these are 5 years long. California is in the middle of one right now. And in some instances, like in California, while the state has the ability to say, provide patients with a produce prescription, it's not mandatory that the health plans in a particular state can choose to offer that option or not. And I would say this is really the start of healthcare integration. These Medicaid waivers often necessitate that someone have a particular diagnosis or a particular social determinant of health that's been identified by a medical provider in order for them to receive the service. So this is moving us towards the future I think many of us are trying to build. And the future I think many of us are trying to build is this idea that we get, I wrote here, a Medi-Cal benefit, but across the country it would be a Medicaid benefit. We rename everything in California. And that would mean that instead of this just being an exemption and part of a waiver, that access to these different services is just built into the way we provide care, which means we wouldn't be worried about losing the program after 5 years. It would be ongoing. It would no longer be optional. It would be required that all of the different health plans offer this service, which would ensure geographic equity, which we know is really important often to serve those who need it most. It also provides long-term sustainability, because if you are a small nonprofit or even a local government, public health department, for example, who's contracting to provide these services, you need to know you're going to be able to do them ongoing into the future to really build up the necessary infrastructure. So we love to see that sustainability. And then this is full integration into healthcare. You are getting paid like a healthcare provider. You are getting patients referred and approved like a traditional healthcare provider. This means that instead of building a parallel system to the healthcare system to provide these food-based interventions, they are getting provided in the same way, shape, and form. So hopefully we're streamlining the access to these different ways to provide food to those who need it. So here's just a little bit more about those Medicaid waivers. Like I said, they are called often 1115 waivers. You'll see a number of states who are listed here who have used this type of waiver to address the social determinants of health or health-related social needs, things like food insecurity or housing insecurity or transportation insecurity. And like I said, we are really living in that middle space in lots of states. So you will see here on this map that those with a sort of purpley star are those that are through their Medicaid offering at least one food-based service. So that might be just medically tailored meals or just produce prescriptions, or as is the case in California, a suite of all of those services. And then all of those orange stars are states that are using some type of flexibility, whether that be an 1115 Medicaid waiver or other statutory authority in order to provide these different types of services. So this really is a direction that the country is going that I really hope we can continue to build momentum with, to make sure that we are moving closer and closer to this just being the way healthcare does business. And then I am happy to say that back in 2022, the White House hosted for the first time in 50 years, a conference on hunger, nutrition, and health. And you will see here this goal over here about diet-related chronic disease, which we've already spent a lot of time talking about. And I think the important thing to note here is that there's obviously momentum from all of the states that I just showed you on that map. But for a long time, there's now been a few years of federal level interest and pressure in this space, a real understanding that food can really help us reach the future that we want to. I think it is also important to note that across the country, the different Medicaid waivers, some of those waivers have been approved under multiple previous administrations. And so I really like to think in many ways and push for hunger as a nonpartisan issue and making sure that we have a healthy populace is good for all. And so the other fun thing about this conference is that, like I said, the previous one was 50 years prior. And an interesting fact about that is it is actually where the WIC program was birthed. So healthy food for pregnant folks and their young children. And so we know that while a conference sounds kind of whatever, does it matter, do I care, that actually the previous version of this led to a huge change in the United States and one that has supported so many mothers and their children over time. And so I really hope that we can continue to push and use this structure to keep our healthcare system moving forward. And now one of my last little sections here is just going to be talking a little bit more about California. I feel like I've given you a lot of high level info, but I want to make sure that this feels tangible to you and in your communities. So I'm going to talk about my community. So first, in California, I already said once, we rename everything. We call Medicaid, health insurance for low-income folks, Medi-Cal. We also named our waiver. So instead of just calling it an 1115 waiver, we call it CAL-AIM. Not that you will ever need to know, but it stands for California Advancing and Innovating Medicaid. And then within that waiver, we used a particular mechanism that we now call community supports, but at the federal level is known as in lieu of services, or ILOS. And this is in federal statute that allows states in their Medicaid program to offer services in lieu of more expensive or higher cost interventions. So what that looks like is you are sort of trading out a traditional state plan benefit for a cost-effective alternative to that state plan benefit. And you're like, Katie, what does that mean? So a really clear example, and then it gets a little fuzzier, which is, let's imagine that I've just been released from the hospital. Let's imagine that I am in the hospital and they don't feel yet comfortable releasing me. There are concerns about my ability to do sort of like acts of daily living, like could I cook for myself, for example? And if I can't, am I going to end up too sick again and back in the hospital? And so there's a chance they might release me from the hospital and send a home health aide to check on me, maybe to produce meals, that sort of thing. But what if instead of sending a home health aide to my home after I've been released, they actually get medically tailored meals delivered to my door? So that is sort of a one-for-one swap, sort of sending a person, very expensive, or sending meals to help get me to the same outcome. So I think that's one we can like generally understand. We obviously see the cost implications of that, but California took this a little bit further. And so the way we've talked about it is, could we also avoid higher cost services in the end? So now let's instead imagine that I have uncontrolled diabetes. In the medium and long term, pending how difficult my situation is, I could end up with a diabetic amputation, which is an incredibly expensive intervention, but one that is certainly medically necessary in particular instances. What if instead we could use a produce prescription to support me in getting my diabetes under control, so I can avoid that high cost of care of a potential amputation? And so this is the framework we've been working in California, using these in lieu of services, AKA renamed community supports, to help us come up with new ways to provide care. This is a little bit of a funny nuance. We applied for these 14 different in lieu of services to the federal government when we were applying for our state's Medicaid waiver. But like I said, we use a statutory authority in lieu of services to make it happen. And if anyone ever feels like getting really wonky about that, you can always reach out. And just to give you an idea of these different distinct services, so medically supported food nutrition is one of them. But for example, it also covers asthma remediation. So imagine that you have asthma and your home has mold or some other problem that needs to be fixed. You could pay for that. Housing and tenancy supports. So that could look like paying first or last month's rent to make sure that you can get into housing and to keep safe in housing. Those sorts of items are all different types of community supports that California is currently covering. And then in the medically supported food nutrition space, there are huge wins and also really complicated situations. So a reminder, these waivers last for 5 years. We are in our final 2 years of CalAIM. And that from nearly the beginning, medically supported food nutrition has been the most utilized of those 14 different community supports. But what's a little crazy to put into perspective is that in the first 3 years, more than 200,000 unique patients have received a medically supported food nutrition service, which, when you just think about it as 200,000 people, feels incredible. You're like, more people have access to the food they need to help prevent, reverse, and treat their chronic conditions. We love that. But you'll see that bolded statement at the end, which often gives me pause, which is that really, we have nearly 15 million Californians on Medi-Cal, low-income Californians who rely on Medicaid. And the most utilized of those 14 community supports has still only reached over 200,000 people. And when you think about that as a proportion, it makes sort of the success of that really questionable. And so I will say we are both incredibly excited by the opportunity and the progress we have made so far, and also realize that there's a long way to go for this to be really utilized to its fullest extent and to be helping as many people as that we think that it could. And so because of that gap, Fullwell, my nonprofit that I work for in the San Francisco Bay Area, takes a multi-pronged approach to supporting medically supported food nutrition in the state. So this first purple block at the top, we run what is called the California Medically Supported Food and Nutrition Knowledge Network. And so this is a statewide community of practice where we bring together community-based organizations as well as government entities who are interested in securing contracts to become Medicaid providers to provide food-based services. We meet every other month for an hour and a half, and we do a deep dive into really complicated Medicaid topics. Like, most people have never thought about how you bill for services in Medicaid. You don't just get a grant at the front end that you then spend down. You are often paid on a per patient basis, and you need to submit what's called claims in order to get that payment. And so these are CBOs, community-based organizations, who have maybe never even heard of a medical claim. And so we do a deep dive into what that means and what you might need to do in order to participate in the program. So I'd call that really high-level technical assistance. And then the next one is region-specific matchmaking. So we acknowledge that hopefully the community of practice is helpful for many, but that if we want to see broader adoption of these services and reaching more people, we need to do some more hands-on technical assistance. So in 4 to 5 regions that are determined by where a health plan has its geography, we find small community-based organizations who are interested in providing these services. We do one-on-one technical assistance. And then we also meet with the health plan in that region, and we try to get them up to speed and make that connection. That's the matchmaking piece. So that hopefully by bringing them together, they can sign a contract to provide these services to their Medicaid recipients in that particular region. And then last, but certainly not least, and probably the piece I talk about the most, is our work on policy advocacy. And so we have done this in numerous ways. First is that we have actually run, that being Fullwell, my organization, and our co-leads, the Food is Medicine Collaborative in San Francisco, state legislation twice and are actually gearing up for a third round as we speak. So 2 legislative sessions ago, we ran a bill. It was Assembly Bill 1644, in case that's of curious or of interest. And that was a bill that asked for these pilot medically supportive food nutrition services in the waiver to transition to full Medicaid benefits. And so we were asking the legislature to pass that bill, which would then have to get approved by the federal government to be implemented in the state. In that first year, we made it all the way through the California Assembly, but unfortunately, the bill died in the Senate in California. We came back together. What do we need to do? Who are the allies we need to build? What's going on? And came back the following year with our a champion in the state, Assemblymember Mia Bonta, who is pictured in this photo. And we ran Assembly Bill 1975. And it did nearly all of the same things as AB 1644 with a couple of tweaks. One is that we actually reduced some of the legislative language and made it more flexible so that it would be easier to implement in the state. However, of course, there were concerns that if we don't write really prescriptive legislative language, well, what's going to happen? Is this going to work the way we intended? And so we built into AB 1975 the creation of an advisory stakeholder group that would help guide coming up with the rules and regulations of what the new MSF&N benefit would be. So things like what's the dosage and duration, what chronic condition should be able to make you so you are eligible to receive a food-based intervention, just all of the things and questions you need answered in order to really run a benefit well. I am both happy and disheartened to say that Assembly Bill 1975, last year's bill, made it all the way to the governor's desk in California. And as some folks might know, we had a pretty crushing budget deficit in the state last year. And the gist of that veto message from the governor was, we think this is a good policy idea. We don't want to encumber additional funds for future years, in large part because we have this big budget deficit. And so for the third time around, we have come back together to say, all right, what can we do here? How can we make this future reality? How do we move from that middle bit where we're in a waiver to that true Medicaid benefit? And so I'm honored to say that once again, we are working with Assemblymember Mia Bonta. And this year, we are actually just doing some budget advocacy to secure funding in order to pay for just the advisory work group to come up with the rules and regulations. And the idea is that we need that budget appropriation this year so that that advisory work group could start meeting in January of 2026 and have an entire year to come up with those rules and regulations before hopefully in 2027, at the end of the Medicaid waiver, these transitioning to permanent benefits so that we can ensure that geographic equity and sustainability of these programs over the long term. And so cross your fingers with me that as we enter into this next phase, we are able to secure that funding and that either the Department of Healthcare Services, as they have indicated, the people who oversee our Medicaid program, decide to transition these services without the need for legislation by 2027, or that we secure the advisory work group this year and next year, we will be back to push for that full and permanent benefit. So there is a lot of space still to go. California would be the first state in the country to make food a covered benefit in their Medicaid program. But we are really hoping that we can really continue to push forward and create the future that we know will really improve folks' lives and get us to the situation we need to be in, where we are really not just treating chronic disease and dealing with sickness, but instead keeping people healthy. And so with that, I want to say thank you all so much. I know that that was 40 minutes of just hearing me talk, and I am not all that interesting. And so I would absolutely love to hear from all of you. If you want to throw questions into the Q&A box, if you need me to go back to a slide. Thanks so much.
Thank you so much, Katie. I do see a couple questions in the chat, and then there's one, or it looks like two in the Q&A. So
great. I love that. So I will start with the one that's in the Q&A. Does your team have a policy memo or other written guides to inform advocacy efforts? Oh, yes, we do. So I'm going to drop into the chat for all of you. This is the Medically Supportive Food and Nutrition California website. If you navigate on that top ribbon to the resources section, I can also, here, I can do us one better here. I forgot I have the power to share my screen. Thank you for bearing with me. Here on our Medically Supportive Food and Nutrition Steering Committee website, you will note that there is a resources tab. And here these are divided into different sections as it relates to advocacy, reports, and then guidance from our state level agency who implements these services. And I would say the advocacy section is probably the best one to get an idea. And I will say this information runs all the way from our advocacy to get food included in our state's waiver. So that's this position paper way back here in 2020, all the way up to, hey, we think that the current rules governing the implementation of these services aren't great. Hey, can you please update those? So I would say it tells the full story here in the state. So thank you for that question. Hopefully that helped answer it. And then I will pop into the chat. One moment. Oh, yeah, fair. Is hunger really a nonpartisan issue? I will say I used to work at food bank. I still work in the space. I like to think it is. I've had lots of questions recently about the change in federal administration as it relates to this work. And I think there are only questions right now, but just to be completely honest, there's sort of two different potential outcomes here. The Project 2025 group, I will say, calls for the complete end of Medicaid waivers, that it would just no longer be an option, that you must implement Medicaid as it is detailed at the federal level. But on the other end of that, we do actually have RFK and then Dr. Oz, who will be in the Centers for Medicaid and Medicare Services. That's who oversees Medicaid and Medicare across the country. And they have indicated actually a really strong support for food and sort of access to healthy food. And so I do not know what the future holds, but as an advocate and someone who grew up in rural upstate New York and now lives in San Francisco, California, I like to push for that reality. So maybe that's a little bit of my soft spot. So thank you. Yes, thank you, Timothy, for your question. There was some context. I gave big picture, sort of differentiating this approach, but could I speak to a bit more about the barriers? Oh, sorry, and this is a two-part question. One moment, y'all. Yes. I love this. So there was like, could I speak a bit more to the barriers, and then just some additional context provided for those who aren't reading in the chat, which is we have GLP-1 inhibitors. So thinking about like the Wegovy's of the world, metformin, so these sort of weight loss drugs that primarily start in the diabetes space, and that those make a lot of money. We are not kidding around on that front. They make a lot of money. And so what is the reality of being able to pay for things like food when we can have corporations and people make a lot of money off of additional medications? So in short, which powerful people and lobbyists stand to lose money from what you're doing, and how can we address root causes despite these influences? I heard while at a food-based organizational conference in general, not just related to food and healthcare, that actually the largest lobbying power and the people that spend the most money in DC are actually food companies. They spend more on lobbying than defense contractors. I cannot fact check that for you. I heard it from the stage at a conference. So if someone ever can fact check me, I would love to know. So grain of salt. But when I heard it, one, I first felt disheartened. And two, I was like, it just means we have to fight and do better. And so this is once again going to be sort of a softer, more personal answer to this question. But I want to thank Linnea for reading my bio at the start. There is what I like to think of a little smile and nod in my bio. I say I'm a lifelong advocate. When I was a little kid, I was in my school cafeteria and they tried to serve us nachos for lunch, like little chips, melted nacho cheese, and you could get a side, like the scoop of really soggy broccoli. And I was livid. I was like, in what world is this lunch. This is my school provided lunch. And I've always been a rabble rouser, and I carried my tray, went to a very small school, down to the superintendent's office, who I knew, and I set it on his desk. And I said, would you eat this? Does this look like lunch to you? Okay, a little sassy. Some people might say rude. Some people might question their child if they did something like this. We never had nachos again. Not saying it was because of me, but I did like it. And so I like to think about that tiny little version of myself who just couldn't take no for an answer. And so we are fighting huge amounts of money in this world, and processed food companies and folks who want to make money from pharmaceuticals. But I think that we have an incredibly clear narrative. I think probably none of you needed to be convinced that food can help improve chronic disease. I showed those 3 slides at the front making that connection, but I hope most of you are like nodding along, like hopefully it gets to the interesting part, what's going on here. And so I don't have a more concrete or eloquent answer for you, except to say that I hope all of the people in this room are the advocates who are going to keep pushing, and that the arc of justice, the arc of time moves towards justice. And so sorry for such a philosophical answer to a really concrete question. And then I've got another one from Casey here. What recommendations do you have for states doing this work that are not as politically progressive as California? Totally. So I just want to point out one of my favorite things about this is that probably the earliest state with a Medicaid waiver to include food was North Carolina. Not bad. Not nearly as progressive as California. And that waiver was actually approved under the first Trump administration. And I would say they have had one of the most successful pilots in the country. I am incredibly lucky that actually an advocate from North Carolina is the person who told me in 2019 what Medicaid waivers even were. He's the reason we started down this path. And so a couple different things. One, it's just totally possible, just remembering that. And 2, I just want to point out that in some instances, there can be actually really fiscally conservative reasons to focus on this. The sort of earlier drugs we were talking about, those GLP-1 inhibitors, those previously diabetes, now often weight loss medications, are incredibly expensive. Healthcare has to pay for them. And that food is a really cost-effective intervention, even in comparison to addressing other social determinants of health. Paying for food or free fruits and vegetables for a pregnant person for 6 months is still way less expensive than paying first and last month's rent for someone. And I want us to get all of those things to encourage people's health. But we are a cost-effective alternative in many ways. And then we do have lots of data talking about those reductions in hospitalizations, which is also money on the table, as well as those modeling studies that show sort of overall healthcare cost savings. And so it doesn't always have to be the warm fuzzies of don't we want people to be healthy. I actually think it can be a combination of both, and hopefully that can help in slightly more politically conservative arenas. And sorry, now I'm back to the chat. There we go. So, and it's got some context here. Any suggestions on how to move Ohio to opening up the waiver system like other states? I use 5-year cycles of funding. Yes. So I think some of that is related to what I just answered in sort of the political context. I would also say, I think there has been some real interest in movement in connecting state Medicaid directors or the person within your healthcare agency who primarily handles Medicaid administration to Medicaid directors in other states. And so if you in your head, you're going, okay, like, dude, our Medicaid director in Ohio is going to roll their eyes at the Medicaid director from California and Massachusetts, because they're California and Massachusetts. Believe me, I get it all the time. Instead, you might be able to say, but what if we had a positive enough relationship with them that they were willing to talk to the Medicaid director in North Carolina or Arkansas, who are starting to use these waivers in sort of more new and creative ways. And I think that that is what I would consider soft power in the advocacy world, which is just you're building a relationship so that that person says, oh, right, like this isn't totally outlandish, and understanding that in lots of these instances, you're bringing in lots of federal dollars. I do not know Ohio's cost match. But I would say here in California, the Medicaid program is about a 50-50 federal to state/local funded program. But there are other states in the country where like Medicaid's like 90% federal funded. And so it all depends on sort of your relationship with the federal government. And so understanding the financing and what's on the table to see if there are other ways to bring in additional funds. And there was a follow-up to that question, which is, am I involved in the Food as Medicine Advocacy Day in DC on March 12th? I will not be in DC on March 12th. I do spend a decent amount of time there with the National Produce Prescription Collaborative and doing advocacy days. But I will admit, I try to limit my East Coast trips a little bit. But if y'all are going to be there, that would be also exciting. And I'm always excited to hear about people's advocacy opportunities. Great. And I've got a question from Zach in the chat. To that point, can you speak to coordinating with other health-related social needs services providers on advocacy? I have to say, sorry, Zach, you don't know, but this question is perfectly timed. So like I said, here in California, we have 14 different community supports. Awesome. Related to housing, asthma remediation, food, for example. And across the spectrum, it's been really difficult to implement. I told you food was the most utilized of those, and housing is certainly next. Things like asthma remediation have had incredibly low uptake. And so I actually spent 2 days last week in Sacramento, California's capital, meeting with coalitions who represent all 13 other community supports. And we came together, particularly we were community supports providers, but also community-based organizations and or representing community-based organizations. And we realized we needed to come together to advocate as a group for changes to the overall structure of the program. So for example, that in most instances, the reimbursement rates for these services are very low. And that we realized we needed a stronger voice, because hearing from just the food people going, hey, it's not enough, please look at me, we were getting ignored. And so I think there is huge power in pulling together people across the health-related social needs spectrum and identifying the pieces of the puzzle where you agree. So in our case, that was things like rates. But there might be an instance where someone looks at you and goes, oh, I actually don't mind how billing works for housing. It's really simple. Someone in the food space might say, they're trying to make me bill every single day. And so can you find ways where you don't have the same problem, but because you've built strong coalition that say the housing folks are willing to speak up for the food folks and the food folks are willing to speak up for the housing folks. So that's definitely from an advocacy position, something we're moving towards. And early on, we weren't working as well in solidarity, and I'm glad to see us move in that direction. And then the additional point to that I'll add is just, we've also seen that it is really helpful when these programs are run by community-based organizations, because my bet would be if you run a produce prescription, you very likely know who is the other person in your community who helps people when they're about to get evicted. And so there's not only helping each other in the advocacy realm, but helping each other better serve the whole patient. And so it is better for us to be networked and in community to do that work. Lene, I want to make sure I get your hand in case this is a keep us moving. Yeah.
Oh, no, we had a question here from Darcy.
Hi,
Perfect.
Kate. Thank you so much. This is really good stuff. I mean, amazing work that you guys have done in California. And I think just showing the roadmap and the path. And I think Ohio is probably where you started in the far right corner of like starting to put together a policy statement. My question for you as researchers in this space, what kind of research do you think we need? Because I feel like what you glossed over and said, yeah, we know it is good for health, right? So, but I'm hearing there's a lot of other challenges along the way. So if you had researchers engaged in the space, what are the kinds of things that the questions that you think would be helpful to explore?
I love that question. Yes, and it is both a gloss over and of course we could do more. So the things that stick out and sort of, oh, good.
I'm going to add one more thing. I should have contextualized research that would move the needle to get to the end goal of integration into Medicaid. So there's research, like, but to get to that end goal, what's the research that's going to make that happen?
I love that question. because I have this all the time, and I'm really lucky to be surrounded similarly to you all guys. I'm in close proximity to some great research institutions. The thing we get asked all the time at the implementation level that we do not have very good research on is duration and dosage. So for example, we have one study, that study out of San Francisco. So that was 6 months, $40 a month to pregnant folks. And the outcome they were tracking was related to birth outcomes. And that's where we found that preterm birth statistic. But what we really need to understand is, okay, well, you did that for 6 months. Would we improve better if that was a 9-month intervention? Or what if it wasn't $40, it was $20? Or do we need to market to local cost of living? So in San Francisco, it's $60 a month, but in where I grew up in Fayette, New York, population 12, it's $30 a month, adjusted to cost of living or USDA-based rates. So we really need to understand those pieces. This is similarly in the context of a different intervention. So instead of, say, a produce prescription, let's imagine you're talking about a medically tailored meal. Lots of the medically tailored meal research is currently about 12 weeks, which is incredible. We've shown sort of reductions in hospitalizations, but I know there's a gap in, well, what if we move, and the word we've been using, probably need to come up with something more clear, is a titration model. Take your sickest patient, they've had a stroke, you give them 12 weeks of medically tailored meals. Is it better to keep them on than 24 weeks of medically tailored meals? Or after 12 weeks, should we move them to a grocery box or a food pharmacy? And then the 12 weeks following, should you move to a produce prescription? Like, is there a way we can move between these that improve cost effectiveness? Because meals are going to be more expensive than groceries that are often more expensive than produce prescriptions. So how do we hit that sweet spot in duration and dosage, and also the movement between? And I would say these are not questions that we have fully fleshed out and answered. And then one I cannot help but mention, and this is where I'm going to use words that I mostly understand, but the researchers will laugh at me. We just need much larger randomized control trials as it relates to health outcomes. We have a couple of them, but we're just looking for more. And hopefully, one of the great opportunities of these Medicaid pilots and 1115 waivers is that we should have large scale, thousands, hundreds of thousands of patients' data through claims, which we have not had when these are philanthropically funded. Your program probably serves 500 patients, and that's not the scale we need to be looking at if we're trying to move Medicaid agencies. Hopefully that helps.
We had another question here.
Yeah, hi Katie, nice to see you again. I just have a follow-up question on that too. From my experience implementing in Indiana, I feel like from the implementation level, we had similar questions, and your point about titration on medically tailored meals was also a question we got a lot on titration, for the lack of a better term, in produce prescription programming, especially working with a Medicaid population who's usually benefit eligible for other items. What happens if you are padding their, like, you're basically expanding their like SNAP benefit or their WIC benefit for the month by providing them an extra $40, and then what happens when they're off of the program? So this question of like the benefit cliff in a different context, as well as that titration, like not just dosage and duration, but like the off ramp, so it maybe isn't a cliff.
Yeah.
I didn't know if you had any experience in any of that, or know of any research in that area, because it is, I mean, similar but also different.
Yeah, 1000% heard, and no, not something I know. I also want to talk about that. I feel really lucky. There's an incredible doctor I work with in the Bay Area, Dr. Shi, and it is one of those things he talks about, which is we would never, sometimes we would never take away someone's insulin if it was helping them to keep their diabetes under control. And if this food is helping keep someone's diabetes under control, why would we remove it after 6 months, 12 months? Like, why would we do these things? And so this is a framing one that I know actually can sometimes be controversial, but I will say it to you all because I think it helps think about the future of this work, which is in California, very specifically, just if you are food insecure does not make you eligible to receive one of these CalAIM community support services. You have to have a medical indication. So diabetes, prediabetes, congestive heart failure, renal conditions, there's a wide spectrum of sort of eligible conditions. But there really is a true and important distinction between a healthcare intervention, food is or food as medicine, and what we like to think of as deeply important social services. And before I give anyone the wrong idea, I know we're at time. We also work on SNAP incentives here in the state. I'm wildly supportive of matching dollars on those dollars, and just understanding that you're making different political arguments when you're trying to move healthcare and when you're trying to move social services. And if we can keep those distinct and strong, I think we will have a better message moving forward. And I know we're at the hour and over. I want to thank you all so much for being with me and your incredibly thoughtful questions. And I'm so sorry to the folks in the chat who I didn't get to. You should be able to get my email. It was at the end here, and anyone, Linnea, are also happy to share it out with attendees. I really appreciate you all. Thanks.
Thank you so much, Katie. Thank you everyone for joining. All right, take care.